exactly. Meteoric. Did you have a question, Dr.
I did have a question, Cynthia Wong. So my question is the guideline that all three societies have, that there be immediate availability of physicians to perform immediate cesarean delivery. And my question is, so it makes kind of intuitive sense that outcomes would be better if that were the case, but are there any data to suggest that that really is true? Do you understand what I'm saying?
I just missed the first part of the question.
So all the guidelines say that the ability, hospitals that perform VBAC should have the immediate ability to perform a cesarean delivery. How did the societies come to that conclusion? Were there data to support that there are better outcomes? Or is it just intuitive or common sense, whatever you want to call it, that outcomes would be better if there's immediate availability?
I think there's data about high volume center with 24 hours availability for C-section, who showed that a decreased rate of perinatal death. This is what the RCOG reported. And there's also data showing that a short interval between decision and intervention is associated also with a lower rate of morbidities. However, that I think this is how the society did base their recommendation on, but and so why the RCOG and the ACOG and the SOGC decided to put an immediate C-section as a recommendation. SOGC retracted their recommendation because of there was a lot of I was there, and there was a lot of pressure of all obstetrician. Mainly those based in community hospital who pressured the society because they didn't want to stop to do VBAC.
Dr. Sokol, do you have
Cindy, I would just add that in the United States, the initial guidelines were that the healthcare team be readily available. And readily was never defined sort of in minutes, other than other guidelines from ACOG, which were that the incision start within 30 minutes of the decision. I don't know of absolute data. I mean, there was one report almost 30 years ago from University of Southern California that suggests if you get a baby born within 17 minutes of a deceleration associated with VBAC, that there were no untoward outcomes. I don't know if that influenced or just anecdotes of bad outcomes, or the medical legal system or environment we live in that changed the phrasing from readily to immediately.
Sheila.
Hello, I'm Sheila Zimmett, and to follow the medical legal theme, the data I've seen on obstetrical claims and recoveries is aggregate obstetrical data. Are you aware of any data that indicates whether or not trials of labor after cesarean comprise a significant portion of that, or is there a perception that it does?
I don't know specific data. I can tell you that we had a case at Northwestern within the last 5 years that the award was $35 million for a ruptured uterus. I know we had another case that was settled for much less, but there was a ruptured uterus and the baby died and did not survive. But I don't think that really matters, because I think the healthcare provider thinks any untoward outcome might come back to haunt me. And that is what leads to cesarean section rates in southern Florida of 50%. And it's not just the monetary value. We had a physician in our hospital who was just a couple years, started there a year or two before me. He had 2 or 3 bad events. I don't even know if they were preventable or not. I don't think he went to trial. I think they were settlements. His insurance was raised so high that he just quit practicing because it was too costly. So it's even the ability just to practice the livelihood that you've been trained for, not even just the amount, how much money you can make, but can you just even practice your specialty? And I don't think there's any doubt that healthcare providers think about that every single day.
Yeah, I agree. Thank you.
Look at it this way, if you get sued out of it, your wife couldn't be the provider.
Yeah, that's all I can really tell you.
Yes, ma'am.
Hi, Wanda Nicholson. I had a question for Dr. Sokol, and this goes back to the Leapfrog survey. I know that they have put out a lot of information about transitioning care to certain hospitals based on higher risk procedures and the number of procedures that certain hospitals conduct and what their personnel is. And so I just wanted to see if you could comment on where you thought that might go in regard to VBAC and cesarean. I don't see VBAC listed here, just normal deliveries and sort of the elective cesarean delivery rate.
Right.
I wondered where that was going.
Yeah, I don't know if Leapfrog will go to VBAC rates. I used Leapfrog, though, as an example of how hospitals are concerned about transparencies. And, you know, as an example, if a sponge is left in the vagina after a vaginal delivery and falls out the next day, no morbidity, no problems, patient suffers no untoward consequences, but that's a reportable event. And I can tell you hospital administrators are terrified of any reportable event that could lead to an untoward comparison of them to their peers.
Go over to the this side.
Howard Blanchett, New York Medical College. Dr. Bouchard, I was curious that the Canadian standard said 30 minutes would be acceptable from decision to delivery, because the data, I was on the faculty at USC when we looked back at the decision to delivery on uterine ruptures, and Ling, one of the professors, 1993 published the data that was referred to just previously, that from decision to delivery, if it was 17 minutes or less, then you had reversible HIE. But if it was beyond 17 minutes, then it was irreversible HIE. And there were a significant number of uterine ruptures at USC during that extensive time period. And so this issue of it's okay, 30 minutes is fine, you know, unless there's some data to suggest that, then the concept of immediate availability should prevail.
You're right, and I tried to contact several persons that were part of that decision, and the decision was not based on literature. And the level of evidence in order to retract your recommendation was they decreased their level of evidence in order to put that recommendations.
On this side.
My name is Michelle Wise, and I'm an obstetrician and health services researcher at University of Toronto, also in Canada. And I just want to take us back to the title of this section, which is what are the non-medical factors influencing trial of labor? And I just want to point out that there's no subsection on provider preference, and I'm guessing it's because somebody looked at the data and found that there really was very little. And I just want to comment on one study that was briefly referred to earlier by Rosillo et al., which is also in Quebec. And they showed that family doctors had, women who attended family doctors for their birth had a higher chance of trial of labor and successful trial of labor compared to women who gave birth by an obstetrician. The concern around that study, though, this is just a comment, not a question. So, the concern around that study, which I think highlights all the data that's been referred to today, is that it's all observational data. And being ClinEpi trained, and lots of people in this room are, you do have to note that there is selection bias to all the studies that we've discussed today. And because of the lack of randomized control trials that show, that randomize patients to a trial of labor or an ERCS, which hasn't been done and probably won't be done, we do have to recognize that limitation